right, a warm welcome to you from Geneva, Switzerland. I'm Reda Sadki. I'm the Executive Director of the Geneva Learning Foundation. And together with Charlotte Mbou, we are going to be your hosts for this special event focused on equity, matters, a practical approach to identify and eliminate biases. Charlotte, we're 1 minute away. How are you feeling about this special event? It's one of many that we've done together. And every time we see this amazing community of health professionals from all over the world connecting, learning from each other. What are you feeling right now?
As always, Reda, it's with great joy and excitement that we are able to receive and to exchange and to learn and share experiences together with health, humanitarian professionals from across the world. And it's always a pleasure to do this with you.
All right, wonderful. And we've got many messages coming in. We're just going to share a few of them. So do introduce yourself. Warm welcome to Sheikh Conte, Rukaya Dauda, who says, thanks, Charlotte. Ukasha Jibril, from northern Nigeria, physiotherapist, Dr. Tusime Ramadan from Uganda, and from the Movement for Immunization Agenda 2030, Dr. Isha Goyal. Don't forget to tell us where you're from India. Where in India? We'd love to know and know a little bit more about you. Modou Lamine Jame from the Gambia, working with the Ministry of Health as a public health officer. Here we go. All right, we're going to kick off today. Again, if you have connectivity problems, and it is something that is likely to happen, you can go to www.learning.foundation/podcast and get the audio version of this. You can also catch up on the recording later. We know many of you will be in that situation. We're here today, of course, to speak about equity matters, a practical approach to identify and eliminate biases. It's the first time at the Geneva Learning Foundation that we're explicitly addressing the issues around bias, around equity, and very much looking forward to this initial conversation, which is step one, the starting point, the stepping stone. And in fact, we're going to start with a personal question. Bias is personal. We'd like to ask you, those of you who are in our Zoom studio, to share a situation where you personally experienced a bias, being treated unfairly or differently. And we'd like to go to Haske Akiti Joseph. Let me see. And ask him to introduce himself and to kick off by sharing really a personal story of biases. Haske Akiti Joseph, are you there? Yes. So do introduce yourself. Yes. We had a brief chat before we went live. No need to say, as I said before, but tell us, what can you tell us about a situation where you personally experienced a bias, being treated unfairly or differently?
Good afternoon from Nigeria. My name is Haske Akiti Joseph, a radiographer from Northwest Nigeria. I experienced a personal bias at the time my child was ill, and we went to the hospital. And we discovered, after a while, sitting at the reception, people were being attended to. People that met us there, they come in and they leave. They come in and they leave. And when I raised a concern, I was just asked my name, and they took my name, but 30 minutes down the line, nothing happened. Now, it had to go to a point where I had to identify myself as a health personnel and also inform them that I have colleagues who work there and their process of doing things is unethical. In a hospital where people are supposed to come and have confidence of being treated equally and fairly, they are being biased, and on what basis? Ethnicity. That is so unfair. It was very, very hurtful, and it opened my eyes to a lot of things that were going on wrong in the health sector as at that time. And up to today, I still address similar issue this morning. So I think it's a global issue. Thank you very much.
Thank you very much indeed. And of course, we're going to be deep diving. We haven't yet introduced our special guests, our guides on the side, but we will when we dive into what to make of these situations. How can we respond to biases, whether they're affecting us or they're affecting others? Next, I'd like to go to Husseina Abba Ali from Cameroon, I believe. Husseina Abba Ali, would love to hear from you, asking you to, yes. And could you tell us a situation, first of all, don't forget to introduce yourself, but then share a situation where you personally experienced a bias, and I believe it had to do with malaria treatment, that there was a difference made. Can you tell us what happened to you and how did it turn out? Because what's at stake with malaria treatment, of course, is your own health and the health of others.
Yes, thank you, sir. My name is Abali Husseina from Cameroon. Yes, I remember a moment during my university years long ago when I fell sick with malaria. I went to a nearby clinic. At that time, I was in university room, so I didn't know well the area. And there was a clinic nearby where I was clearly weak, had a high fever, and all the typical symptoms of malaria. But because I was a young woman, from the outside, the nurse assumed I was just exaggerating. She barely examined me, gave me paracetamol, and told me to rest. I later found out that several other men who came in after me with similar symptoms were tested immediately, like right now, right away with malaria. And they received full malaria treatment. One of them even joked like saying they always think girls are just tired, but not sick. I had to return 2 days later, much worse, and only then did they take me seriously and confirm it was malaria. That experience stayed with me a lot. It showed me how gender bias, even unconscious, can delay treatment and put lives at risk. It's also why I now advocate strongly for equitable, respectful care, where every person's symptoms are listened to, regardless of how they look or who they are. Thank you.
Thank you very much indeed. Now, you, Husseina Abali and others, Haskia Kiti Joseph, and so many others, over 100 practitioners, professionals, researchers, policymakers shared experiences ahead of the event. And today we want to honor you as contributors who are really making this peer learning from each other, learning from experience possible. We're going to share the full list of those of you who contributed to the event, and we'll be hearing your voices, your stories, and thinking and learning together today throughout this event. So we're now going to go through the full list, and we've mixed the English and the French in alphabetical order. If your name is not there because you submitted late, we'll be updating the list. We've also shared, we can also share, and I hope Charlotte has the cheat sheet to be able to share the link so that you can go and look at the list, what we call the honor roll. Here we go. So these are the practitioners who took time out of their busy day in order to share their experience, contribute to peer learning. Learning from each other doesn't happen by itself, doesn't happen because of experts. It happens because of each and every one of you, no matter who you are. You have experiences that you can share that can help make a difference. So we honor contributors today. Now we're going to dive right in with the first question, the first sort of case or scenario or situation, a time when you saw some people get better health care than others. What did you see? Who got better care? Who got worse care? What did you do to help? So that is what we're going to ask you. If you are on YouTube, Facebook, X, Twitter, LinkedIn, you can type your answer, and we're able to share it on screen. We're not able to keep up with all the messages because there's simply too many. But this is a question, the first question that we'd like to examine together. A time when you saw some people get better health care than others. And for those of you who are guests of honor, and with us in the Zoom studio, please raise your hand if you'd like to share your experience in relation to this question. It's also fine if you want to share in relation to a different question. So this is where I'm going to turn to Charlotte, and in the meantime, we're going to look at. Okay, Will Holden. So let's go to Will Holden. Will. Please do introduce yourself. You don't need to say that you've already introduced yourself before we got started. Tell us who you are, what you do, and then tell us about a time when you saw some people get better healthcare than others.
Yeah, thank you. My name is Will Holden. I'm from Dublin in Ireland. I work as the owner of a social enterprise called the Emergency Logistics Team, and I'm semi-permanently based here in North Iraq. But reverting back to the specific incident where I saw bias relates to the cholera epidemic in Yemen in 2017. My role at the time with an INGO was to review the medical supply chain for that NGO. I wanted to, I suppose I had to get out and see as many of the diarrhea treatment centres as possible, as many of the local offices as possible, and to understand exactly the issues and the challenges they had, because the main issue was actually getting medical supplies was taking a huge amount of time, like months. But as I went out and I visited the local offices, and the further away from the main centre in Sana'a, I noticed something very quickly, was that there was two things really which sort of made this issue sort of bigger than it should have been. One was that the local staff didn't really have proper training. Now that was obviously due to the conflict. I could understand why this happened, but I could see very clearly they did not have the proper training on how to receive medication or the equipment required for the cholera response. They didn't understand how to ship the goods correctly, how to correctly store the goods. And actually, they had a lack of confidence as well in voicing their concerns and suggestions back to Sana'a. So I could see, and this was really a bias in relation to knowledge, as I mentioned. And when we could work with the main office in Sana'a, I was able to clearly explain what the issue was and some simple suggestions on how to improve both the communication and the processes. And I found one specific office, the sub offices actually, which there was one guy there who actually really had a good understanding of exactly what was required. And so we tasked him before I left with going to all the other offices in North Yemen to train everybody as much as possible, considering it was an active war zone at the time, going through a cholera epidemic at the very same time. So it was very complex for everybody. And as I said, I wouldn't point a finger of blame at anybody, but it's working in conflicts, which I've done over the years in many countries. It's very, very complex and very difficult. So that's my experience. Thank you.
Thank you, Will. Holden, we'll come back. We'll begin to explore the stories like the ones we've heard so far. Today is about the bias-free framework, a framework from 2006. And we're very pleased to be sharing this framework with you today and to explore with you how it can be used to make sense of the kinds of situations that we've heard so far and that so many of you have shared. This is where we want to make a marker pause and also introduce our first guide, because we do want to honor the co-author of the bias-free framework. Her name was Margaret Eichler, and I'm going to turn to Mary Ann Burke, her co-author, to introduce herself and also to tell us what she'd like us to know about the life and work of Margaret Eichler.
Good morning, everyone. Thanks all for coming. Margaret and I started this work back in 1995 and spent a couple of years developing the framework after we had been working on some gender-based analysis tools. And we realized that we had a very powerful tool that it could be applied to all the different social hierarchies in many different situations. And over the next few years, we workshopped it in every continent but Antarctica and found that it was applicable, that people could use it everywhere. And about Margaret herself, she was a really good partner to work with. She had years of experience working on non-sexist research, so she had a very good grounding in sort of gender issues. And she just had a very sharp and keen mind that could zero in on problems very easily. We had a lot of fun together doing the work. I'm not sure what else to say here, but just that we really miss her and her spirit. So, but the work is going on, and it's exciting to see that this initiative will keep things going for us.
Thank you very much indeed, Marianne. And we honor Margaret Eichler today, and we hope that we're honoring her through this event. Now, something remarkable happened with this event is that we saw large numbers of participants registering, requesting their invitations above and beyond what we have seen for other special events of the Geneva Learning Foundation. And we're very pleased to announce that there are 4,785 policymakers, researchers, practitioners, health leaders registered for today's special event, as well as humanitarians and many other job categories. But those are the ones we want to focus on. And at the Geneva Learning Foundation, we believe in and practice the power of collective learning. We believe that community health workers can see barriers that researchers miss. Global researchers can spot patterns that you cannot see at the local level. Policymakers understand system constraints that affect implementation. And it's when these perspectives connect that we can find better solutions together. So just a reminder of what makes a powerful story, as today is very much about storytelling, about you telling the stories of what you have observed, what you have experienced as health professionals working for communities all over the world. And really, we invite you to really focus on not generalities, not personal opinions, but a real world situation that you personally lived and experienced, specific details about what happened, who was affected, your personal actions, their results, barriers encountered, and then how they were addressed, and lessons learned that change your practice. So that's what we're hoping to dive into today. 3 sets of questions really broadly. There are many more questions that some of our guests of honor answered, but the first is about unequal treatment, a time when you saw some people get better healthcare than others. The second one is about different needs. Different people need different kinds of help to be healthy. And if you have an experience there, we invite you to share it. If you're on YouTube, Facebook, X, Twitter, LinkedIn, you can share in writing and we'll share your comments and try to show it on screen. The third broad category is unfair care, where you saw someone get poor health care because of who they are. So we'd like now to open the floor to those of you who have, to our guests of honor who are with us in our Zoom studio. And then in the second part of the event, once we've heard a number of stories and really have begun to feel what we are experiencing together as health professionals facing these kinds of challenges, then we'll turn to our guides on the side and go through together, walk through this bias-free framework to explore how it can be useful making sense of biases. So Charlotte, over to you. Who shall be our next speaker? I think we've already heard a number of voices.
Rather, we have Marie J. Nzala Diekevova, whose mic is already unmuted, trying to apply our rules of fairness in terms of gender. So, Marie, I don't think you can. Please go ahead and please do start by introducing yourself.
Thank you so much for giving me this opportunity. I'm so happy because this is a good time we share all our information experience we got during our admission in the healthcare system. Yes, there is a many issue with the healthcare system. Many people are being discriminated because of their color, whatever. I don't know, but me myself, I was not me, but my child was like a victim of that system. She was not neglected, but because of maybe the color of our skin, the doctor did not really give her the appropriate care in the beginning because she was suffering for kidney failure. Then when I went later to another hospital, the doctor saw my reaction that I'm not happy the way they treat my child. I need something quick to be done. And they really changed their actions. And they realized that I'm also a healthcare professional. And they asked me, Mom, where have you been trained? Blah, blah, blah. I say, it's okay, this is the time. Finally, my daughter received appropriate care, everything, dialysis, treatment, blood transfusion, she recovered. So Then later, after maybe 3 or 4 years later, the UK introduced the system of Equity Act 2010, which allow people to be treated fairly, whatever your color or skin, diversity, background is really applied in the UK now. I thank God for that. But I also been in that system.
Thank you.
Mary, before you go, can you introduce yourself, please? Tell us who you are.
I'm Mary Jacqueline Zala in London, UK.
Thank you, Reda.
Yeah, thank you, Charlotte. It's true, we missed the introduction. We're going to deep dive in a few minutes, but I already want to turn to Mary Ann Burke. Mary Ann, warm welcome to you. We haven't introduced Bridget yet, but of course we will. And we'd like to know when you've heard a number of stories, and for you as a specialist, with the expertise that you have, and with a bias-free framework, of course, in your mind, what do you hear when you hear a story like Maria Diekevova's, what she just shared? How do you begin to make sense of it? And we'll get into the the framework itself, but just as a human, and as a researcher, as a practitioner, how do you feel when you hear a story like this one?
I mean, all the stories are very compelling, and you hate to see that some people receive different treatment than other people, or don't have their needs met at all. But I would like to just go to a little higher level of analysis. When I was listening to all these various stories, Will stuck out a little bit, because Will was talking about problems that come from a hierarchy, but there wasn't really an oppressive hierarchy at work. And so that's what we try to focus on, is when there's an oppressive hierarchy that's hurting people. So, like where people are treated differently because they're women, or because their skin is a different color. Will's was a hierarchy, but it was based on people having the education within an organization and not having proper training. So it was a different kind of hierarchical problem. So I thank Will for bringing it out, because I think that's one of the things that we really want to focus on, and Tool is focused on, is oppressive hierarchies.
Thank you very much indeed, Mary Ann Burke. And we'll deep dive into right now. We're still listening to stories on unequal treatment, on different needs, on unfair care. And we do want to already share with you sort of 3 key questions that we'll be getting into with our guides on the side, Mary Ann Burke and Bridget Burke. Question number 1, what oppressive hierarchies are operating in this situation? Is there one? That's the sort of starter question. Who is in the dominant group and who is in the non-dominant group? And then question 3, what problem types are involved? Is it a situation about maintaining an existing hierarchy? If so, how? Are there relevant differences between groups that are being ignored? Are different standards being applied to different groups? And if the experience, and some of you, not everyone, but some of you described how things turned out, what solution you found, you were able to put together, does this actually reduce or eliminate not just the surface problem, but the oppressive hierarchy itself? And of course, that begs the question then, what is an oppressive hierarchy? It's a hierarchy that hurts some people but not others. And here I'd like to turn to Mary Ann again and ask you, well, this seems like both a simple concept and something that's incredibly complicated, that we're all embedded in different ways. What have you found over the years in engaging with very different types of audiences? What have you found to be the most effective way for people to sort of acquire the concept so that they can then identify if there is an oppressive hierarchy, and if so, what it is?
It's easier to understand a hierarchy when you're the person experiencing the oppression. So you can see that and feel that you are being treated in a way that takes away your dignity, that your needs aren't being met, and you can see that somebody else is in a position of power that creates that situation. So it's easier when you are the recipient. It's harder when you might be the one who is either consciously or unconsciously oppressing other people, and to be aware of that. That's a harder thing to understand. And that's one of the reasons why we developed the framework, so that there are questions that people can ask of themselves as they're preferably starting something, as opposed to getting a problem into place in the first place. And sometimes hierarchies, you're inside of a hierarchy. You have a place in the hierarchy that is not at the bottom, but you might be in the middle, and that can be problematic because you have to do as you're instructed. There are rules to follow, and you might not be able to correct a situation that you see easily. You have to deal with the people above you. So that's also something that's problematic. And also
hierarchies
can change over time. Like sometimes you can be in a dominant position, other times you can be in a non-dominant. So it's contextual. It's understanding where you are in a certain situation, and that can also change, your age, your health status. So, there are places and times where change can happen. But no matter what, your power, the amount of resources that you have access to, are all dependent on where you are in that hierarchy. So people at the top have access to all the resources that they need: time, money, political power. People at the bottom tend to have less of that and less able to access those resources.
Thanks, Marianne. So we have Loretta Awukpeme, who says, here's how she defines it. And this is a great, we invite you to respond to the questions, just as Marianne and Bridget, as our guides, are going to be responding to the questions. You can also contribute. She says, oppressive hierarchy is when there's somebody using their power of authority to oppress and hurt other people, especially by creating a barrier from accessing things that should have been easy to access. Is that a full definition? Is there anything you'd like to respond to, be more precise or be more specific in terms of how Loretta is defining oppressive hierarchy?
That to me? Sorry.
Yes, Marianne. Sorry.
Yep. Yeah, no, I think that's a good start.
All right. Let's go to Loretta. I hope she's able to speak. And again, we're looking at 3 questions: unequal treatment, different needs, and unfair care. So thanks, Loretta, for helping us define what is an oppressive hierarchy. A warm welcome to you. Don't forget to introduce yourself, and what is the experience that you would like to share with this group around an oppressive hierarchy, the biases, inequities that you've been confronted with. And I hope you're able to speak to us. All right, unfortunately, it looks like Loretta is not able to speak. So back to you, Charlotte. There's lots of, many great contributions. Also, Abdulia Ba says, this concept suggests that certain groups experience more oppression than others, often leading to competitive dynamic amongst marginalized groups. The idea is rooted in belief that some forms of oppression are more severe or harmful than others. All right, back to you, Charlotte. Who shall be our next speaker? Whose experience shall we hear from next?
We have Onuosi Chika Odiri, whose mic is already unmuted, Retta.
All right, wonderful.
Oh.
Onuosi, over to you.
Yes, good morning, good afternoon from here. I'm Onuosi Chika Repeater from Boeing State, Nigeria.
Yes, we hear you loud and clear. What is the experience that you'd like to share around unequal treatment, different needs, or unfair care?
Okay, on this aspect of treatment to people, though I've not experienced it, but I've witnessed so many areas that people were biased, was not given the full treatment they need as a patient. Like one recently happens, a pregnant woman was about to deliver in the hospital when they reached, and the lady was not feeling well. She was not strong. The doctor said they need to deposit 500,000 naira before she can touch the woman. But in the aspect, the husband was begging, pleading with the sum of 100,000 naira in order to rally round and get the remaining money amount, telling the doctor that he can sell all his livestock to make sure that the wife is okay. But the doctor couldn't attend to the woman, and he was referring them to a distance far away. And along the line, the woman gave up. The child died. But we have tried to talk to the doctor in some aspect, and the doctor realized that what he did was so biased. And again, the man, now people are responding to the man. Even the money is there now, but the woman is no longer alive. So these are people that are trained to take care of life. Instead the life will be wasted, property should be wasted, but the doctor didn't give it to first in place. But we have resolved the issue because that was a private clinic. And secondly, I have a brother I took to the health facility 2 days ago. He confirmed that he's having the symptoms of malaria, but when we get to the OIC, the officer in charge of the health post, he was actually tested, but they said no malaria. The test read negative. But this my brother was complaining. He's feeling the symptoms inside him, but they say they won't give him drugs because the result reads positive. There are some cases like this, and we try to negotiate with the health provider that there are some cases like this. One will be tested and it will be negative, but the person is still having malaria. But in 2 days later, we went back to the same hospital, and there was found that he is totally down. And that was when they can now treat him with infusion of drip and the rest of them. So we have been moving from different hospital to emphasize on this area as a facilitator and community volunteers. So thank you.
Thank you very much indeed for your contribution. And again, we invite everyone to be asking considering these questions that you see on your screen. In what you just heard, what oppressive hierarchies are operating in this situation? Who is in the dominant group and who is in the non-dominant group? And then what problem types are involved? And this goes back, you'll find more complete, comprehensive guidance in the bias-free framework. I hope Charlotte's able to paste in the link for anyone who hasn't downloaded it yet. You can see there were almost 1,000 downloads ahead of the event. Now, in order to make sense of how we can answer these types of questions, why that is helpful, and what that can give us if we're concerned about the biases and we want to focus on reducing them, challenging them, addressing them in various ways, we're going to look at one, maybe two cases, and we're going to do that with our guides on the side, Marianne Burke and Bridget Berg. And here I'm going to try to pull up on screen the first experience that was shared by someone who's a community support worker who chose to remain anonymous, and who works in a youth shelter in Canada. Charlotte, I think it would be good for all of us to read this together, but if you could read this out loud, because it is poetry about bias, we'd love to hear you.
Yes, Reda, with pleasure. Indigenous youth faces 3-month wait while others wait just weeks. During my time working in a youth shelter, I witnessed a situation that made it clear the health system was not treating everyone the same. One of the youth in our care, a 17-year-old indigenous boy, was experiencing severe anxiety and depression. We referred him to a local mental health clinic for support. However, while other non-indigenous youth from the shelter were able to access care within a few weeks, he was placed on a much longer wait list, over 3 months. I noticed that every time he went to appointments or emergency services, he was often met with suspicion or treated as if he was exaggerating his symptoms. There was a clear lack of cultural understanding, and no indigenous mental health workers were available to support him. Thank you, Rena.
Thanks, Charlotte. So this is a real-world case shared ahead of this special event, and we're now going to keep this in mind if you haven't had time to jot down notes, because now we're going to be working through these questions. What oppressive hierarchies are operating in this situation? So hierarchy, something that hurts some people but not others. So go ahead and type your response, how you look at this, looking at this situation, what hierarchies you see at work. You have race, ethnicity, gender, socioeconomic status, ability status, age, citizenship, language, religion, sexual orientation, body size, education. This is not an exhaustive list. It's not in any particular order. Then you have other types of hierarchies: geographic, occupational, lifestyle, institutional, digital, housing, transportation, family structure, colonial, knowledge system. So if you're watching online, we know there's a short delay, so we'll be looking for your responses coming in. But we invite everyone in our Zoom studio to kick us off and tell us what oppressive hierarchies are operating in this situation, described by a community support worker. So Enei Ode says, let's see, socioeconomic and ethnic. Amy Oyekunle says oppressive hierarchy, race, citizenship, gender, education, culture. Anyone else right now? We have, okay, Haske Akiti Joseph, so ethnic and cultural. Yes, any other? All right, and then Vincentia Adwoy Safori says the hierarchy working there is ethnicity and culture. Let's see if we can go to Vincentia. And Vincentia, we're going to ask you to unmute. Oh, and Rian Tenveen says that there's technological hierarchy at work here. So Vincentia, are you able to speak to us?
Oh,
right.
Hello.
Yes, a warm welcome to you.
Vincentia.
Do introduce yourself.
Hello, I'm Vincentia from Ghana.
Wonderful.
Hello, can you hear me?
Yes,
yeah.
Yes, thank you. I think there might be a slight delay, but this story about from a community support worker working in a youth shelter who was witnessed a situation that made it clear the health system was not treating everyone the same. And so you've responded, the hierarchy, the oppressive hierarchy working there is ethnicity and culture. Can you tell us why you think that's the case? What is it about this that leads you to select those two aspects?
Yes, in my opinion, I think probably the person is not from Canada. And so that is why he was not receiving the utmost care from the healthcare workers. And it's totally wrong. We are all human beings, wherever we find ourselves, whether in UK, USA, wherever, we are all human beings and we should be given equality. Here in Ghana, when a white person is taken attends our facility, we take care of him. And so when we find ourselves elsewhere, they shouldn't look at our color or gender or anything. They should be given equal opportunity to access care wherever we are. So I think the person wasn't treated well, and it shouldn't be encouraged anywhere in the world. Thank you.
Thank you very much indeed. Let's go to Amy Oyekunle. Amy, would love to hear from you as well. What oppressive hierarchies do you see at work in this first experience that we're digging in and looking at it through the lens of the bias-free framework? But first, do introduce yourself first.
Hi, I'm Amy Oyekunle. I am a social worker researcher from Lagos, Nigeria. Did a lot of work around health research on COVID, so my experience is there. I mean, for this case study, very glaringly, I see the issue of the fact that he is a young boy, not from Canada, so he's not indigenous, and hence part of the treatment and lack of
Sorry, just to correct Amy, so in the Canadian context, he is actually amongst the first people in Canada. Everyone else came after his ancestors, as he is an Indigenous youth, if we're talking about the youth and not the community support worker.
Well, okay, so yep. I stand corrected. So I think that cultural lack of understanding, I think when you use Indigenous, people understand that, well, they're different. So there's something different about this person. and hence we don't understand it. So
Right.
that is why I said, race culture. And I think also for me is, yes, it's a youth clinic, but sometimes there is bias around the age and around the gender as well. We tend to see others as well different. We don't understand why, we don't question why we look at things in that way. So I feel those things are quite glaring in this case, which is why he kept on being put on a wait list for that long.
Yeah. Thank you, Amy Oyekunle. And it's not by accident we chose a case from Canada dealing with First People from Canada that involved First People from Canada knowing that this is a global problem. This is bias is not something that is specific to Africa or Asia or Latin America. And also knowing that our two guides today are from Canada. So I'd like to turn now to Bridget Burke and Bridget Burke. They made it explicitly clear that what they did not want to do was to be asked what's the right answer to the oppressive hierarchies question or any other question. So with that in mind, I'm going to ask them to comment and reflect and share really what they're hearing as they've been listening to this dialogue. And Bridget, a warm welcome to you.
Thank you. I'm be here today. I have been working with the bias-free framework for probably 15 years now. And so it's very exciting to see all of you thinking about how it can be applicable and help you understand some of the biases that you're encountered in your own lives and practices. It's really great to hear you all working so critically with this case study and really unpacking some of the biases within it. And there's a lot here that's right on track in terms of understanding this particular case. So we always start by thinking about what is the hierarchy. And yes, we see a lot of what you're saying. We would think about race and ethnicity, but more specifically in this case and in the Canadian context, colonization as an important hierarchy here, where there's a difference between predominantly Eurocentric, healthcare staff that has a Canadian European background versus our First Nations people in Canada who have experienced oppressive and genocidal conditions throughout the history of Canada. And we see that reflected in bias in healthcare today. And so there's a strong connection to one of the experiences that was already shared. We had someone sharing today that they had an experience of bias where their symptoms were dismissed because they were a woman, right? They weren't taken seriously because it was thought, oh, women complain a lot, they over-exaggerate their symptoms. And in this case, we see a very similar bias operating based on indigeneity, where someone who is First Nations from an Indigenous community in Canada is treated as if their symptoms are made up or exaggerated because of that colonial hierarchy in place and that bias based on Indigenous status. And I think all of the other analyses that have come up, age can definitely be a factor here, right? Thinking about youth and our assumptions about youth versus adulthood, gender as well. We can think about the ways in which our gendered expectations of masculinity and mental health in particular might play into this situation. So all of this is really great analysis to see coming from the participants today.
Thank you very much indeed. Bridget, and a warm welcome to you. Amy Oyekunle says, really interesting to hear this. We're now going back to the question list, and you can see that the next question is who is in the dominant group and who is in the non-dominant group. So please, if you'd like to type into the chat, or if you're watching on YouTube or LinkedIn, you can type there. We're not able to show all of the responses, of course, and then we're actually going to skip to question 3 while you are responding to question 2 in the chat. To get into the problem types. And this is a key concept of the bias-free framework and the triangle. For those of you who have not looked at the bias-free framework, I hope that this will make you curious enough to go and look and see to determine if and how it can be useful to you. So what we have are 3 types of problems And they have letters. So it's not an alphabet soup because it is only 3 letters, D, F, and H. So you may be wondering, if you haven't looked at or worked with a framework, what is D, F, and H? So I'm going to go through it quickly, but then we're going to actually try it. And I'll be asking you to type into the chat what problems you see. So if the situation is maintaining an existing oppressive hierarchy, then it's an H problem. If there are relevant differences between groups that are being ignored, it's an F problem. And if there are different standards being applied to different groups, then there's a D problem involved. Now, you can have a problem that includes all 3, or you can get more specific, and it's in that specificity that we can actually begin to make sense of some of the using the bias-free framework as a lens. So you can see the 3 questions more explicitly here. And again, we're going to go back to this situation, this experience that was shared of a youth facing a 3-month wait while others wait just weeks. Is it, and this time I'd like you to type, is it a D, an F, or an H problem, or some combination? So you can just type the letters into the chat, and we'll be showing them on the screen. We still have some of you who are sharing the oppressive hierarchies. That's fine, but now think about, is this violating someone's human rights and dignity? Then it's an H problem. But it can also be an F problem if addressing this inequity requires recognizing differences and providing different treatment. And then if addressing this inequity that you have before you on the screen requires standardizing treatment, making it the same for everyone, and eliminating differences that are not justified, then it's a D problem. So right now, we know we're all thinking, and we'll see who's the first. Okay, so Traian Rasmus says it's an H and D problem. Anyone else? And thank you, Traian, for being the first one. Phyllis Goody says it certainly is a D problem. Let me put the problems up here. Kosi Aira says it's an F and D. Traian Rasmus said H and D. Okay, we have a second vote for H and D. And again, one of the points that Marianne and Bridget, as we at the Geneva Learning Foundation have been learning about the bias-free framework, is to say, this is not a popularity contest to see which letter of the alphabet is more popular or which problem is more popular. It's really about doing critical thinking about a situation and trying to really make sense of what are the different problems involved. All right, so we have, all right, Husseina Abali says all 3. Now, I'm going to start with Traian Rasmus, who I believe told us before in our studio that he has, let's say, a historical relationship with the bias-free framework. So Traian, I know you work in the field of education. Here we're looking at a situation involving a community support worker. Would love to hear from you. Do introduce yourself. Tell us who you are and what you do, and then help us make sense. Is this what combination of D, F, and H problems is this situation about, and why?
Okay, hello everybody. So I was and still working in the education field, even I am a little bit over 70, so I'm retired but still working with the university. I think it's an age problem because it's about what has been said already, maintaining the hierarchy for those who were colonizing Canada. And D, because it's a double standard. It's one measure for a Canadian who, let's say, have an European origin, and a different standard for the First Nation, as indigent people are called there in Canada. So that's how I argument my opinion.
Okay, all right. And you have worked with the bias-free framework before. Can you tell us where you go from here with the bias-free framework? It's not just about coming up, assigning a set of problems to a situation, is it?
Well, because I had the chance some 20 years ago to meet Marian Burke here in Romania while I was working with UNICEF. I heard about that a few years later, sorry. And more recently, we are still keeping up with activity with the university and at the center from Bucharest University, which is called the Center for Researching and Promoting Equity in Education. We are having different events, and next month there will be an event, and I'm going to say something about the BSV framework. Wonderful. That's why, in particular, it was the reasons to attend this meeting, to find more how it is viewed and which are the whole world issues, and also to hear again Marian Berg's voice and see her face.
All right. Well, we're really pleased that you're joining, and we know there's a long history and some very impressive work done using the bias-free framework. We hope to hear more from you and others who've used the framework in the future, and we're looking forward to seeing what this group of health professionals from all over the world, from Africa, Asia, Latin America, is going to do with this framework in order to challenge and address and respond to biases. We have now, really, we've gone through the D, F, and H. And again, we're discussing together in the context of this special event, this scenario, an experience shared by a community support worker who works in a youth shelter in Canada, working with Indigenous youth who finds himself, I believe, an Indigenous boy, a 3-month wait, while others wait just for weeks. And we're looking for, once we have identified which problems we perceive in a situation, an experience like this, I'd like to turn to Mary Ann and Bridget, who are here with us, and we're very pleased that they are. How do we adjudicate whether the identification of one or more problems is correct, useful, incorrect? What's at stake with this kind of diagnosis? And because there are many health professionals in the room, that notion of diagnosis is likely to make sense. Help us. Where do we go from here? And how do we go from the sort of general H, F, and D to the specific problem types under each one?
Right. I don't think that it matters. I think the first thing is that people recognize that there are problems, and from my perspective, there are problems of all types. And I think once we can unpack it and see what the problems are, then we're able to put correct solutions into place. The problem is, if you don't identify the correct problem, you can put a solution into place that might exacerbate the problem or make it worse. So I think the first level of analysis is to recognize that there are problems, and then to kind of probe deeper. And, I see that as what people are doing with it. Bridget, did you want to add anything here?
Yeah, I would just add, I think you're all on the right track here, right? Like, there's a lot of different layers that we can analyze a case from. And so in terms of correct diagnosis, sometimes there are multiple diagnoses, right? And in this case, we definitely have a D problem. We have a double standard where there is a longer wait period for Indigenous youth compared to non-Indigenous youth in Canada. That's a clear double standard. But we also have a hierarchy problem, right? That double standard is coming from the fact that there is a hierarchy where within the Canadian context, within the history of an ongoing racism and anti-Indigenous sentiment within Canadian society, there's a hierarchy of better care and better treatment and recognition of the humanity of non-Indigenous patients compared to Indigenous patients. And so if we just address the double standard, but we don't address the underlying hierarchy, the fact that an Indigenous patient is seen as perhaps lying about or exaggerating their symptoms because they are Indigenous, and think about where is that coming from, right? In Canada, that might come from stereotypes about Indigenous people. That may be this harmful negative stereotypes that an Indigenous youth might be drug seeking as opposed to actually having legitimate mental health concerns, right? Just addressing the double standard doesn't address the underlying hierarchy. So we need both. And then others have also pointed out that there are F problems, failing to examine differences. And that's also true, right? Because of the history of colonization, because of intergenerational trauma, the history of residential schools in Canada, Indigenous youth might have different needs than non-Indigenous youth who are seeking healthcare. And so there's a failure to consider whether they might need culturally specific healing practices, whether we might need Indigenous healthcare workers to ensure cultural safety for these youth within the healthcare system. So there's definitely all three problem types, and all three need to be addressed in order to create a more equitable situation for the patient.
And I just would like to add that the point Bridget just highlighted about needing trained Indigenous health workers was also one of the D problems. So they're underrepresented in the healthcare system. So the problems relate to the youth, but they also relate to the health system itself and the lack of Indigenous workers who can provide that safe, culturally safe treatment.
Thank you very much indeed to both of you. This is the special event, A Practical Approach to Identify and Eliminate Biases. It's a special event hosted by the Geneva Learning Foundation. We're going to look at a second experience. And again, deep dive this time, maybe go one level further. We only have a few minutes left officially for the session. But because we know many of our guests of honor have not yet had a chance to share their experience, and the experience they shared in writing, we'd like to give as many of you as possible a chance to speak. So we'd like to ask if you are a guest of honor and if you would like to share your experience, please raise your hand, and we're going to propose to extend this event beyond the top of the hour mark for which it was planned. We know many of you have fascinating stories, experiences to share. So please do raise your hand if you'd like to be added to the list. We already have a number of people who are on the list of speakers and our guests of honor, so we look forward to hearing from you. Here is then the second case experience shared, and this one too, it was quite uncommon for people to remain anonymous, but with Mary Ann and Bridget, we zeroed in on these two as interesting ones to discuss. And so Charlotte, over to you. This one is about women, children, and elderly displaced without proper care, but there may be many other things involved.
In my country, Burkina Faso, we are victims of insecurity with terrorist attacks in the north of the country, causing massive displacements of people to save their lives. During these displacements, women, children, and the elderly are victims of gender-based violence because their specific and practical needs are not taken into account. Children suffer from malnutrition, pregnant women do not benefit from antenatal consultations, and the elderly do not receive age-appropriate care. Young women are often victims of rape due to lack of shelters for all households. Thank you.
Thank you, Charlotte. Yes, so we're going to start with the D, F, or H, and that's the sort of general level. In the actual bias-free framework, not in the context of a short event like this, then you would deep dive to look at the different dimensions for each type of problem, and that's really where you can gain the most through the analysis using the framework, I believe. But I would like to ask again for this case, this situation, this experience shared by a gender and social inclusion specialist who's based in Ouagadougou, Burkina Faso, chose to remain anonymous. Which problems do you see? Is it an H problem, an F problem, a D problem, some combination? So Esther Yakubu says it's F and H, that we're failing to examine differences, and that there's an existing hierarchy, an oppressive hierarchy that's being maintained. Anyone else? And if you're watching on YouTube, LinkedIn, we know there's a delay, but you are able to also contribute and we can share your response on screen. Okay, Phyllis Goody says F and H. And Alina has a comment. So she's a psychologist working with victims of domestic violence, and she deeply relates to this case from Burkina Faso. She's seen how vulnerable groups, especially women and children, are often overlooked when systems don't adapt to their real practical needs. Abubakar says F and H, so failing to examine differences, maintaining an existing hierarchy. Zainab Ahmed agrees with Abubakar. So this one, Bridget, actually, I would like to turn to you first. Yes, Emmanuel Musa wants to go back to the problem again. Hang on, I keep going to the wrong slide. Sheikh Conte sees an F problem. Adam Ibrahim sees an F and H. So let's go to Alina first, and then we'll go to and ask you. Yes, Alina, you said you're a psychologist working with victims of domestic violence. Can you introduce yourself? Tell us which country you're from and how this experience shared from Burkina Faso resonates with you.
Hello, I'm glad to be here. I'm from Romania, and I work as psychologist with victims of domestic violence for 10 years, I think, more than 10 years. In this case, I think that H and F problem, because their dignity is violated and they lack access to basic services, protection and support. And it's also an F problem because equity means I think recognition that different groups need different care. Pregnant women need antenatal consultation. The elder need age appropriate care, and young women need protection from GBV. Whether in Romania or Burkina Faso, we must move away from one size fits all responses and commit to trauma-informed, inclusive. I think that it's time to return to the idea of community and mutual support. The pandemic and the war have only divided us, and we need more empathy, more advocacy for the right and of the marginalized and the victims. Those of us who can speak, I think that this is the time.
Thank you very much indeed. All right, I'd like to go to Bridget now because you had quite a compelling reaction about this particular experience that was shared, and we'd love to hear. Take us through it, and maybe I know that this is you'd much rather you'll take the time and work with the group we have here rather than come in with your perspective. But I suggest we deviate a little bit, if you'll allow it, so you can tell us in this particular case, in this experience that was shared, what H, F, and D problems do you see at work, and how you look at an experience like this and make sense of it through the bias-free framework.
Thank you so much, Rita, and thank you all for sharing your analyses of this case. So normally with the bias-free framework, we always start by thinking who's in the dominant group and who's in the non-dominant group. And in this case, I think we can all agree that those who are displaced, and among those, they highlight women, they highlight older folks, would be in the non-dominant group. And part of the reason we do this is to think about levels of intervention. And we can think about problems and bias problem types at different levels as well. And so when analyzing these problem types, we can think about the immediate health needs, right? We can think about, is the healthcare system fully addressing the needs of these displaced populations? And we can see some hierarchy issues and oppressive hierarchies operating where maybe the needs of these displaced persons, women, elderly folks, children are not being met. Maybe their housing needs are not being met. But we also want to think about what is the root cause of of them even being displaced, or them, in the case of the women, experiencing gender-based violence. And so we want to think about what hierarchies are there at play within the case, and maybe even in how the case is framed. So we want to think about, are there ways in which, in this case, there's a gender hierarchy where the way that women and sexual violence is being used as a weapon of war, right? Where women are being objectified. How is that being addressed, and how can we address that? And we would see a hierarchy problem in instances where women are being blamed in some cases for their experiences of sexual violence. And this doesn't always happen in an overt way, this blaming. Sometimes it can be a subconscious way that it's done. And we see that come up a little bit in this case, right? Where we have the logic of women are experiencing sexual violence because their needs are not met, because they don't have access to shelter. And so we would argue, if we look at it at that level, the solution would be, well, let's build a shelter, right? But that places the responsibility on the non-dominant group to protect themselves. And so thinking about who is in the dominant group, who is having the responsibility to change this problem, in some cases, it actually would require us to challenge these forms of masculinity, right? Challenge these patriarchal norms that have allowed women to be objectified and for sexual violence to be used as a weapon of war. And so actually, thinking about it from a hierarchical perspective, the intervention that we would advocate for, of course, meeting the immediate health needs, the immediate needs for shelter, but also thinking about how we can develop gender initiatives that challenge these forms of masculinity and these patriarchal measures that perpetuate gender-based violence.
Thank you, Bridget. So that would be, digging in a little bit into the different categories of problems. For the H problems, I see H6, victim blaming. What else would you see in describing across the sort of H, D, and F dimensions? What else would you pinpoint?
We have maintaining a hierarchy in that patriarchal practices are accepted and not brought into question. We have objectification in that women are being objectified, and that violence against them and against their dignity is being accepted and normalized. We also have an F2 problem, decontextualization, where healthcare services aren't taking into account the diverse needs of displaced populations as well, right? So there's a lot that we can dig into here. And part of the case study is going through each of the different problem types and thinking about, does this apply to this case? And if so, how? And the reason we do that is because they require different solutions. So someone earlier said, they're having a little bit of trouble telling apart an H and a D problem, that there seems that there overlap between them in the chat. And I think that's important to raise because each of these problems, an F problem where you're failing to examine a difference, or a D problem where you're treating someone different when they actually should be treated the same to have a fair outcome, require different solutions, right? So the solution to a D problem where you're using a double standard is actually to create the same treatment for groups, right? And the solution to an F problem is to actually recognize difference and accommodate that difference, right? So the solutions are going in opposite directions. One is failing to account for difference, where you actually need to give them different treatments, and the other, you need to give them the same treatment for a D problem. And then for an H problem, we need to challenge the underlying hierarchy outright. And as we've seen with both of the cases, often there's overlapping problems, and so all need to be addressed in order to create a more equitable situation for those involved.
Thank you very much, Bridget. So we are over time, and deliberately so, intentionally so, because we want to leave more room to hear your experiences. And also, I spotted this message from Husseina Abba Ali. We started with you at the beginning of this special event. I hope you're still with us and still have maintained good connectivity. We'd like to hear your thoughts. We know that many in our Zoom studio and online have been confronted with and work in situations of armed conflict conflict, see the consequences of war for vulnerable groups. So if you'd like to speak specifically to that, how you see an experience such as the one that was shared by this gender and social inclusion specialist, do raise your hand. If you'd like to share your experience as well, we can return to that, because that was our commitment to those of you who are guests of honor who took the time to share an experience ahead of the event. So I'm going to turn to Charlotte to identify our next speaker. I'm going to say a little bit about what happens after this special event. We are going to be asking you, one, we'll be sending you a questionnaire in which we ask you questions about what value was created through your participation. And this is something that you can do in order to earn certification, but it's also something we appreciate because it helps us improve and gives us a sense of how useful an event like this is in fact. But then there'll be a second questionnaire because we are hoping to develop a program, a course, starting with an inaugural course that would kick off on the 2nd of June to really learn how to use and apply the bias-free framework and incorporate it into your work. So we'll be asking you, would you take a course like this? Would this be of interest to you? Would this be useful to your organization? We'll also be inviting organizations to consider becoming partners of the certificate program if we decide to go ahead and launch this program. So we're really looking to listening to you, learning from you, whether this is something that could be useful to your needs, to the challenges that you face, as we always do in terms of how we work at the Geneva Learning Foundation. So Charlotte, back to you. We're looking for, please raise your hand if you're a guest of honor and would like to share before we close this special event today. We'd love to hear many more voices. I know that there was Rukaya Dauda has tried several times but had connectivity issues, and we have Abubakar Darbo. Charlotte, over to you.
Okay, Reda, would Rukaya, are you able to speak? Or Abubakar Darbo? Okay, Rukaya, over to you. You're unmuted, and please just start by introducing yourself.
Okay. Hello, can you hear me now?
Yes, we can hear you, but speak a little bit louder.
Yes, hello everyone. This is Abubakar Dabo from the Gambia Red Cross Society.
Okay, I am Rukaya Dauda.
Oh, so finally we lost both Rukaya and Abubakar.
All right, let's bring Rukaya back. Yep, Rukaya.
Yes, let's listen to Rukaya and then we'll get to you, Abubakar. Thank you.
Okay, I am Rukaya Dauda, a physiotherapist from Nigeria, northern Nigeria. So, my experience with some people getting better healthcare than others narrows down to the socio-economic status here. So in this part of the country, when I say,
all right, this happened, I think.
There's this thing about you being well, other part being in the lower class. So I've seen in numerous cases when a high-ranking person comes to the facility. Can you hear me?
Yes, you're breaking up though. I don't know if there's a way to maintain good connectivity or make sure your microphone stays connected. There is a problem, but we're doing the best we can to really listen to you and understand your story.
Okay. So, okay, when these high-ranking officials come, they are booked for physiotherapy and everything. They pay their money and even give tips. So you find out that they are giving more attention, less premium with low registration money or having part of the money. So they are tend to be neglected since they are not even paying full, and they are trying to beg for some time before they are able to balance the payment. So you will see that virtually they are giving less health care services and sometimes not being attended to. While these people that are influential and in the highest rank, they come in, pay everything, even paying additional. So you see everyone lurking around them, giving them the best treatment they can afford, even additional treatment. So all this I have seen has made the less privileged to not get the optimal healthcare services they deserve, making them to have low general outcome in their health. So I I don't know how. Can you hear me?
Yes.
Okay, so this is a very, very critical situation here, and I wish there is a way in which all of us can collaborate to, if we can bridge the gap between high status, high people in the highest socio-economic status and those in the low economic status by like bridging a gap using NGOs or social welfare officers and the rest. And also, if we can create like a donation account for those that are less privileged. What I did in my own case, I tried to gather all those that are less privileged, like give them a different treatment. So when they come, they try to meet me, because when they meet me, I try to strategize their plan and everything towards them, so they don't have to bother about the barrier between socioeconomic status anymore.
Thank you, Rukaya Dauda, and we hope that this program, whether or not we launch this program on equity in health and this inaugural course on the using the bias-free framework, will depend on you and others. How many people respond? If there's an insufficient number, if then that doesn't really. You show that there's a strong interest in such a program, that you, and it is legitimate for you to say, actually, I don't see how this can help me. If that's the case, then an educational program. You may need other things. You may need resources. You may need, so we'll see what we can provide as an education organization and invite members of the network who are joining this new nascent community to continue learning, not just learn from each other, but also to support each other in the in undertaking effective action that is likely to make the biggest difference possible. So thank you for that, Charlotte. I think we have time maybe for one more, and I realize we're deliberately over time, and there's just so many of you who shared experiences. We wanted to give a little bit of overtime, just like in the football match when there is there's so much to do. We're not scoring goals here, but Charlotte, I hope you can point us to our next speaker.
Yes, Reda, it's Abubakar Dabo, which we cut off earlier on. So, right. Abubakar, your mic is unmuted, so please proceed.
Yeah, hello everyone. It's a pleasure to be here. I have been following keenly. So I just have a simple case to dilate on, that is about the Gambia. Normally the bias that is actually identified here is we have this public and private health centers or hospitals or clinics, you understand? So on normally what happens is most of the public hospitals or health centers or clinics are places where the less privileged go to, because these are places where when you normally visit there, or they will tell you after consultation with the doctor or the nurses, all they will do is to prescribe medications for you to go and buy them at pharmacies. So the burden of you going to from your house to the health center or to the clinic or to the hospital to get the best medications that you don't get at most often you don't get at public hospitals. You understand? You only get the best medication at private hospitals, and in these are places that are very much expensive, for poor people or for vulnerable women or for families or people in the rural areas, you understand? So most often they don't get the best healthcare that they deserve, because the best healthcare, the best hospitals are privatized, you understand? So those are normally visited by wealthy people, you understand? So you will realize, that sometimes you would go to the hospitals, you see very malnourished children, you understand? What happens? They don't have anything good to eat. They don't have any good medication that they can get. So normally when they are referred or to pharmacies, medications are expensive. For example, you prescribe 2, 3, 4 medications that I need to buy. You understand? You need to buy injection, you need to buy this. So you as a family man thinking about how to feed your family, you have this sick child who needs the best attention when it comes to medication you cannot afford, because when you go to the pharmacies, they are very much expensive. So that is the problem here. Just of recent, we've seen in most of the social medias, in our televisions, where hospitals, you see patients lie on the ground, you understand, and these are public hospitals. These are hospitals that are not giving that much needed attention in terms of the necessary supplies that they would actually need. So that's the problem that I actually have identified as far as the Gambia is concerned. Thank you.
All right, wonderful. Thank you. I think this will be our last testimonial. We recognize and acknowledge that some of you still have a hand raised, but unfortunately we have another session that we need to start in a few minutes. So Charlotte and Maria have given me a heads up about that. We wish this is only the stepping stone, the first step, step one. We have scheduled already a follow-up session in which we'll be reviewing what you told us about this event, whether or not you see a need for this program, and whether or not you'd be willing and able to participate in the first course. So this, for this, around these issues of equity matters, and probably most likely focused on effective use of the bias-free framework to make a difference in your organization. So that is it for this step one today. We hope that you'll join us in 2 weeks, and also invite your colleagues, anyone else who you think in your network, in your organization, is likely to be concerned about, interested in working to strengthen equity in the health work that you do, will be most welcome. We want to thank our guides today, Bridget Burke and Mary Ann Burke. Mary Ann, of course, co-author of the Bias-Free Framework. Thank you for being with us today. We're holding the session for the Francophones tomorrow, and looking forward to that as well. And of course, we want to honor one last time the co-author of Mary Ann Burke, Margaret Eichler. Once again, thank you and goodbye. We've got messages coming in so fast, they're hard to keep up, but this is your chance to say goodbye, or more like see you in 2 weeks. I'm sure if we were in a room in a physical space, we would be hearing real applause. Thank you. And this is really an amazing community. We did not know what level of interest there would be in this issue of equity. You've given a really powerful answer today with this first event. Thank you. Last chance to get a message if you'd like to say goodbye, if you'd like to thank each other. I really appreciate this amazing community. Thank you.